I will have the pleasure to be your MC today. Um, we would like to acknowledge that we are gathering on Treaty 6 territory and the homeland of the Métis. We will also want to recognize that some of you may be attending from Treaties 2, 4, 5, 8, and 10. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples. We pay our respects to the traditional caretakers of this land. World Breastfeeding Week is celebrated every first week of August in commemoration of the 1990 Innocenti Declaration, which states, as a global goal for optimal maternal and child health and nutrition, all women should be enabled to practice exclusive breastfeeding, and all infants should be fed exclusively on breast milk for birth to 6 months of age. This year focus is on closing the gap for services for mothers and babies, and it showcases the need to improve breastfeeding support to reduce inequalities that exist in our society, with a special focus on breastfeeding in times of emergencies and crisis. The team is aligned with the Sustainable Development Goals. In Saskatchewan, 95% of families breastfeed their newborns. However, 39% of them continue doing exclusively for at least 6 months. According to Health Canada, overwhelming majority of Canadian women start breastfeeding soon after they give birth, and more than half stop within 6 months. As organizers of this event, our aim is to raise awareness and inspire action on themes related to breastfeeding within our institutions, towns, and cities. We also recognize that not all people who give birth and lactate identify as female. During this presentation, you may hear families, lactating persons, and mothers, as well as breastfeeding or chest feeding, and we will consider these terms interchangeable. I would also like to acknowledge that as a researcher, I work on diverse projects, some of which are funded by Dairy Farmers of Canada. With that reflection, I leave you to Professor Hassan Batamparas, who is not only an expert in food security among underserved populations, but also a champion enabling the conversation around breastfeeding and families' health.
Hey, good afternoon, everyone. Happy to be in here, and thank you, Michelle, for the nice introduction. Uh, as Michelle mentioned, World
We can't hear you out here, Hassan. Could you hold the mic closer to your mouth?
Is it better now, Tyson?
Yes.
Our IT person behind the scene. Yeah. Yes. Yes, it's an annual celebration, and it's celebrated in 120 countries. So it's not just about Canada or developed countries. I remember my first exposure to this day, and also the initiatives related to that comes back to late 90s when we decided to have our hospital kind of work on it to receive the certificate for healthy. Okay, what's the name of it? Let me check the exact name of the certificate. The certificate's name is Baby Friendly Hospital through UNICEF. And we were so proud of that at that time. This year, as Michelle mentioned, the theme is closing gap. And you may ask why? Why closing gap and then trying to promote more breastfeeding? One side, we have overwhelming evidence that breastfeeding is really important, and exclusive breastfeeding in first 6 months is very important. But the other side, we see that there are many challenges and barriers toward moms to go to that direction. So as an example, I can tell you that based on Canadian Community Health Survey data, nationally representative data, what is happening in Canada for breastfeeding moms, around 17% of them are food insecure. That's a big number. And then among food insecure moms, half of them, they cut breastfeeding after 2 months. They can't continue that. And there are many reasons why, and you may hear from our esteemed speakers, panelists today, why this is happening, bringing the example of our own province, Saskatchewan. So going back to the history, Zoe mentioned, sorry, Michelle, Zoe and Michelle are in here. Michelle mentioned that it was in 1992, first time that it was celebrated. The organizations behind it is UNICEF, WHO, and also individuals, government, and many other organizations. Again, 120 countries, more than 120 countries are involved in that. And that's a very good way of promoting breastfeeding that is happening. We are a bit late, only 1 day late, but we are happy that for the first time in Saskatoon or at University of Saskatchewan, we are celebrating this event. So with that, I'm privileged to have with us today a panel of experts. I know individually some of them for many years. Johanna is in here, are working in healthcare system. They are advocate and promoter of breastfeeding. I would like to invite our panelists, Dr. Shela Hirani, Mrs. Johanna Bergerman, Mrs. Sarah Smoky Day, and Mrs. Andrea Too Good to join us. I know that Andrea is joining from Regina and is going to be online. Please join me on the stage. So each of our panelists will have around 15 minutes of presentation. And then after that, we're going to be having, I'm hoping, very active and engaging Q&A session. Please be ready for asking questions. Now, allow me to introduce our first speaker. Okay, I need to come sitting here, standing here. Okay. Yeah. Okay. Okay. Dr. Shela Hirani is an associate professor at the University of Regina. She's a maternal and child health nursing professional, researcher, lactation consultant, and an advocate for baby-friendly initiatives. She's actively involved in breastfeeding advocacy in diverse care settings and health promotion of vulnerable women and young children. Based on her contribution in 2020, the World Health Organization recognized her as one of the 100 outstanding nurses around the world. Oh, congratulations for that. You are very well accomplished. Dr. Hirani received several other honors recognizing her contribution, including the Queen Elizabeth II Platinum Jubilee Medal in 2023, Saskatchewan Multicultural Leadership Award from the Lieutenant Government of Saskatchewan in 2022, YWCA Women of Distinction Award 2022, and CIHR Vanier Graduate Scholarship Award. That's amazing. Very good achievements that you have had. But on the top of that is her passion to what she does as an advocate in Canada and other countries promoting breastfeeding and dismantling breastfeeding barrier. She will share some of the insights that she had. She's leading baby-friendly movement. You saw some videos at the beginning, the productions of her team in her lab. And I am amazed. As a researcher and advocate myself, I'm amazed with the work that you are doing. So she is right now an elected board member of the reputable international, national, and provincial organization, and she's serving as an editorial board member for reputable journals in the area of global health. Now, also on the side of it, she's very much dedicated to train the next generation leaders in the area of breastfeeding. Shela will share insight to the gaps in social services affecting breastfeeding practices of refugees and immigrant mothers in Saskatchewan, Canada. It is yours, Shela.
Thank you so much, Dr. Hassan, for this lovely introduction. And it's my great pleasure to be at this forum and share the stage with the lovely speakers here. Two are here and one is online. And as my today's topic that we identified was to highlight some of the gaps in the social services that are affecting the breastfeeding practices of refugee and immigrant mothers in Saskatchewan. And I'm an associate professor from the University of Regina, Faculty of Nursing, and definitely breastfeeding is my passion. Today, I will try to do justice with this topic in limited time. Sometime, like I'm so much passionate about this topic that if you're going to give me the whole day, I will just keep talking about this particular area. And because I really want to have some changes in effects, and I know that it's not one person's job, like multidisciplinary and interdisciplinary professionals do play an important role in bringing that change. So you all are the champions who are attending this event in person or online, or would be joining in the breastfeeding advocacy in one way or the other. So next slide, please. So I would start my today's presentation with a land acknowledgement. I'm a South Asian settler on Treaty 4, the land of the Cree, Sato, Dakota, Nakota, Lakota, and the homeland of the Métis Nation. I appreciate the privilege I have been given to live, study, work, and raise my family on this beautiful land, Saskatchewan, the land of the living skies. I'm mindful of broken covenant and strive to make this right with the land and with each other. Next slide, please. I acknowledge that there is no actual or potential conflict of interest, and the research that I'm presenting today is funded by SHERF and Jim Pattison Children's Hospital Foundation. Next slide. So starting with the importance of the breastfeeding during the early years, and as we can see in this particular slide, that definitely the neuronal development in the early year, especially when the child is in the mother's womb, right from the time when the mother is pregnant, there is some evidences of the neuronal development, and this neuronal development actually reached to the complex state. So the more network form, it means that the growth and development, especially the brain development, is happening in a very rapid manner. But this particular state is something that the 90% of the brain development happens in the first 6 to 7 years of the child's life. It means that the initial few years are so much sensitive, so much crucial for a child's life, and that should be the one that should support environmentally, nutritionally, that type of the neuronal development, so that child can be physically active, socially, emotionally, cognitively, in all aspects of the life. But definitely the role of the good nutrition is very, very vital. In talking about the nutrition, I would say that the role of breastfeeding is very, very important here in the first few years of the life, because breastfeeding is the safest option for the baby, and also it's readily available. It's like a clean, contains the antibodies that even prevents the baby from the variety of infection that even lowers down the mortality and morbidity rates. As I mentioned, that it contributes to the child's brain development, promote the growth overall. And even when it comes to the bonding between the mother and baby, this is something which is very robust kind of the way to promote the bonding between the two. Research have proved that breast milk has the analgesic properties. So even when the child is undergoing any kind of the minor procedures, the breast milk could be the one that can actually have the analgesic property, and one can breastfeed the baby and prevent the child from the pain perception. And even like in the long term, it prevents the obesity as well. So in all ways, it is the a wonderful kind of an avenue for child to achieve the greatest percentage of the neuronal network and neuronal development. On the other hand, there are many dangers of formula milk, because it is not, no doubt, like it's putting the more pressure economically. It's a very expensive option, having the risk of contamination. The risk of contamination, because it requires the water. At times we don't know like how contaminated the water is. It requires the supplies, and even when in the plant, when wherever it is being prepared, so it is being dried up, and even at that time there are kind of a contamination that can even come into account. And we have seen many recalls in the past few months from the products like those. So those are the add-on kind of the risks that we are putting forward the child life into that risk. Also, it has increases the risk of infection, just like pneumonia and others. because it does not have any kind of the antibodies. It increases the risk of allergies, intolerances, dental issues, because definitely a teat or artificial nipple is required, and it's very different from the mother's nipple. So that type of thing even have a jaw development that can lead to the dental issues, and definitely in the later in life, obesity and non-communicable diseases like heart issues have been reported. So overall, considering many dangers of formula milk and considering very high benefits of breast milk, WHO has highly recommended breast milk in the first 6 months as exclusive breastfeeding. And after that 6 month, definitely child could be given the solid food as well. But in the first six months, the exclusive breastfeeding with no water, no juices, no solid, no honey, or any kind of the pre-lacteal feed, and also breastfeeding initiation in the first hour of birth is something which is an ideal that has to be promoted and taken care of. Breastfeeding on demand is another important aspect, and continuation of the mother's milk up to 2 years and beyond is something the ideal set by WHO, and that is something that we as a healthcare providers or as an interdisciplinary providers have to really take care of these kind of the promotions so that we can let child to have the maximum benefits. Even during the time of pandemic, breast milk was considered safe, and WHO highly recommended their mothers, even if they were COVID positive, they said that even the benefits of breast milk is more than the risk. So it should be continued. So even we can think of that even in the time of disaster, displacement, or with the vulnerable situation, this is something an ideal kind of the nutrition for the young babies. Talking about breastfeeding, there are many vulnerabilities, and there are a number of vulnerable population globally. Some are facing poverty, some are facing disaster, some are facing displacement, and some are facing like housing insecurity and number of other challenges that actually directly or indirectly affect the breastfeeding practices of mothers. And my focus on my research are mainly the vulnerable population, because they are the one who definitely need the extra level of support. And one of those population that I would be sharing about in today's presentation are about the refugee and immigrant and newcomers. And talking about immigrant and refugee mothers who often experience the trauma, the family separation, forced migration from one country to another, because if their host country or their home country were having the disasters, they definitely never thought that they would be migrating to a new host country. But definitely because of disaster or because of war, they really have to take that step to move to the another country. Immigrant usually choose to come, but refugee, it's for them, it's a forced displacement. On the other hand, immigrant are the one who choose to be in a new country to give better opportunities and better life to their next generation. So definitely, when they migrate to the new country, they often face the social disconnection, and this vulnerability often has a negative impact on their overall well-being and the breastfeeding practices due to variety of physical, psychological, emotional, and social stressors. So the challenging transition of the newcomer, immigrant, and refugee mothers are many. Some of those like are language difficulties in the host countries, at times do not have the access to the health insurance, or the breastfeeding counseling facilities are not available in their own language. And even there are at times like the limited access to the healthcare services. So in many mothers who are in this vulnerable state migrating to a new country, they are even at a very, very high risk to not to initiate the breastfeeding or continue the exclusive breastfeeding or have the overall continuation of the breastfeeding as per the WHO guidelines. In Canada, we all the time welcome many refugees and immigrants from different part of the world. And in this situation, we're gonna see that in Saskatchewan, that has a noticeable increase in the immigrant and refugee families from different part of the world. And many of these families are with the young kids. And in Saskatchewan, we're going to see the people migrating as a newcomer, as a refugee, as an immigrant from Asia, South Asia, Africa, Europe, Middle East, Afghanistan, Eritrea, Ethiopia, Myanmar, Rwanda, Somalia, Sudan. And now, because of the war, we're going to see more migration from Ukraine and from other parts of the world. So even like we can see that there are diverse culture, and there are different kind of the languages that they definitely speak. So we have like more variety, we have more diverse population, and most of them are like in a vulnerable state because of either the forced migration or their chosen displacement. So looking at the Saskatchewan, that has a noticeable increase in the immigrant and the refugee population, but has only one healthcare facility so far with the baby-friendly initiative, and the other is having the silver status. So we are still having the limited number of healthcare facilities with the baby-friendly status. It means that they are following all the 10 steps of recommended. So that's something that's one of the gap, and the other is that there are also limited healthcare facility that provide the specialized care and services to the immigrant newcomers and the refugee mothers who are with the young babies. So overall, there was a significant gaps in the knowledge surrounding breastfeeding facilitators and barriers affecting the breastfeeding practices of immigrant and refugees. So definitely there was a next move to identify that what are some of those challenges and how to better respond to their challenges, what could be the some of the need-based interventions. So here the aim of the study was to identify the gaps in the social services affecting directly and indirectly the breastfeeding practices of immigrant and refugee mothers. I utilized a critical ethnographic study design because that mostly fit with the vulnerable population where you are dealing with so much of the vulnerability. They already face the social inequality in their home country, and now in the host country, there are more layers of challenges that they are facing each day, which is affecting their breastfeeding practices. So, Saskatchewan was my setting. The data was collected using multiple methods, including in depth interviews, having the field observations, and undertaking the document analysis. So, I've just combined the two studies in here. So, basically, 30 immigrant and 27 refugee mothers having the children aged 1 day to 24 months were interviewed, having the in depth interviews and understanding their context, their surrounding, their housing situation, their overall care aspects, and the health needs. So this research was funded by Jim Patterson Children's Hospital Foundation and Saskatchewan Health Research Foundation. My collaborators were United Way, Regina, Saskatchewan Health Authority, Regina Open Door Society, and Saskatoon Open Door Society. So I would start with some of those barriers and having some of the reflections surrounding that what was happening, what were some of the gaps. So one was the psychosocial barriers that many refugee and immigrant mothers were facing. They had a feeling that there is no social support, especially from the extended family members who are now far away. They were previously providing them the guidance on breastfeeding, but now they are no more in touch. They cannot travel to their home country back. And then on the same side, there is no neighborhood support, there is no healthcare support, and even there were so many socio-cultural constraints. Many felt that they were facing so much of the racism because of their accent, because of their language, because of their appearance, because of their skin color, because of their dietary needs or their healthcare needs, or because of their dressing. And many were facing the economic challenges because many who, when they arrived, they were not able to find or secure the jobs because initially some extra documentations were required and they were not aware of the processes, and at times it was a racism that laid them behind. And then even many were not having the command on English language or French, and that really not qualified them to certain jobs. So that really affected the breastfeeding mothers because it really increased their stress level to an extent that they really felt that I wish that I would have died. Like, I've literally interviewed moms who really had that feeling that they really wish that we would have not migrated to a new country or even died in our own home countries. One of the participants shared their perspective as I quote, as an immigrant, we always miss our family to be around us, to emotionally support us. For me, I was tired psychologically more than physically. I needed psychological support so much, unquote. So this really reflects that they were going through a lot mentally and psychologically. Other few barriers that they were facing were related to healthcare because many were not having the direct access to the healthcare or transportation. Many were living very far away where they can afford the housing. And that was even making them more vulnerable to access the healthcare. Even those who had the deliveries in the hospital here in Saskatchewan felt that the quality of the mother baby care was not that good that should be, and many mentioned that there was some violation towards the breastfeeding practices. Even they had to breastfeed, but nurses were offering them some formula, and that was even making their life more miserable. Many mentioned that there was no interpretation services. And one of the mother who I interviewed was severely depressed when I asked her that what happened. So she mentioned that there was somebody like who came up with a form, and they asked her to sign it. She signed it thinking that she's delivering the baby in Saskatchewan hospital, and that's it is for. She was in the hospital to deliver her seventh baby. So next day she was taken to a kind of a operation theater, mini theater, and she came back and she came to know that somebody actually gave her the consent form for the tubal ligation, and this procedure was already performed on her by the time she get to the knowledge of this particular aspect. And she really got so depressed that she could not breastfeed the baby at all. She said that I'm so scared and afraid that my husband gonna divorce me because I may have to go back to my home country. It was my decision when to stop my child's number and all that, and at least there should be some counseling, some explanation to me. So that was another layer of the example in here that I can just mention from my participants. One of the participants mentioned, as I quote, some nurses were very welcoming, but others were not very friendly, and they would be unhappy if I asked them questions. Sometimes I used to take my elder daughter with me because her English is better than mine. One nurse refused to answer my daughter's question, told my daughter, it is not your business to know. I have told your mother the situation. If she didn't understand it, it is not my problem. As a migrant mother, I suffered at the beginning. I was so sad and embarrassed. Unquote. Next. Few mothers also mentioned that there was a lack of encouragement, inadequate knowledge from of the healthcare professionals on the expert kind of the views that they were looking forward when the child had the muscle issue or like the child was with the tongue tie. So nurses generally trained were not knowing that how to tackle the tongue tie and all, and even there were not many lactation consultants available in the healthcare setting who can give them the expert kind of services at that time. Many mothers mentioned that they were not knowing where the breastfeeding counseling are being offered, how much money they have to pay, or is it free of cost. Many mentioned that in the healthcare setting, at times when they visit the clinics, the doctor's clinic, they don't have the availability of the private room to respond to their child's hunger in those healthcare settings. Also mentioned that many mothers mentioned that there were limited follow-up care and services during the time of COVID, and there were insufficient community-based healthcare services. Racism was very much common in the healthcare settings where they went for the care. There were lack of culturally sensitivity, and many mothers mentioned that they were Muslims and they were offered the food that were having the pork and bacon in it, and same with the other mothers who were Jewish and the kosher food was not there. So they mentioned that while being in the hospital postnatally, they were not eating at all and still trying to breastfeed, and that was causing more trouble because they were not able to catch up with their nutrition while being in hospital. Next. Another quote that I would like to share here, as I quote, I couldn't eat the food that was provided in the hospital. The food wasn't halal. At the beginning, they asked me to write my dietary restrictions. I told them I do not eat pork, no meat or chicken for me. They didn't offer halal food. My husband or my friend bought me food. I only ate the breakfast in the hospital, unquote. Few other barriers included the environmental barriers that mothers were facing that were directly and indirectly affecting the breastfeeding practices. Many mothers mentioned that the COVID-19 pandemic really disconnected them from the healthcare professionals. They were not able to visit the hospital. Even with the breast engorgement, if they were going to the hospital for care, they said that it's not an emergency. You can go back. If you have heart attack, only then you come back, and nobody was giving them any care to them at that time or available to care for them with the breast engorgement and breast abscess kind of the issues. Few other mothers mentioned that cold climate in this in the host country or in the host province, they are really facing this kind of a situation when they don't have a transportation and they have 6 babies. They don't have the daycare facilities where they can keep their younger children, and provincially they are not allowed like to keep the young babies at home, and they had another one in their lap. So it was difficult for them to go back and forth to the hospital with their babies with the no social support available generally. Next. Few other environmental barriers included the non-acceptability of the breastfeeding in public spots and variety of public spaces like hospital, workplaces, airports, restaurant, public park, public transportation, where they really demanded that there should be some kind of a breastfeeding support to all mothers, including us. And then the other workplace barrier was another very highlighted by mothers. Many were part-time workers or casual workers, so they were not entitled to have the maternity leaves. And because of that, they were not able to breastfeed their babies. They were struggling financially to meet those needs. And but at the same time, if they were asking for the pumping time at work or space to breastfeed their babies or space to pump their breast milk, that was not like available at all in their workplace, and nobody was understanding to offer them that type of the support. So overall, a key recommendation from this work is that it's very essential to involve the newcomers, immigrant and refugee mothers and their family member as a partner whenever we are designing any kind of the innovative or the need-based programs, because we should not be all the time in the offices or far away from those mothers, not knowing the context, developing something. When we involve them, that's more applicable in their context. So this is one of the recommendation to promote, protect, and support breastfeeding practices and design the interventions that are very need-based. Another recommendation is that the breastfeeding of immigrant, newcomer, and refugee mothers can be promoted through the healthcare support, culturally appropriate services, interpretation services in the healthcare settings, implementation of the baby-friendly initiatives, community-based breastfeeding campaign, and the follow-up services at the community level. Other recommendation is that we are not like done with the COVID. At times, every time we feel that how many waves we're gonna face and how many more such a kind of a similar events we're gonna have. So definitely use of social media, helpline, telehealth is also recommended to offer the breastfeeding counseling to the mothers in different ways in their own preferred language, so that we can assure the cultural sensitivity in our care and services. Also, the partnership and collaborative efforts by the interdisciplinary professionals, governmental and non-governmental agencies, another aspect that is quite important to have the robust intervention, have a social support, have a resilience building program, promoting the health and capacity building of the immigrant and refugee mothers in our province and beyond. So here are a few of my publications. If you would like to access the full text, I would be happy to share the full text of those articles. Yeah, yeah. So these were like some of the images, and these are the references that I used in my today's presentation. Here are my contact details. If you feel like accessing some of those articles, I do hold a YouTube channel as well. That is also on the Vimeo as well. So If you are looking forward to have more resources in this area, you're happy to contact me or refer to some of those links that are available. Thank you so much, everybody, for your attentive listening.
Okay, thank you very much, Dr. Hirani, for the presentation. I can relate to whatever she said as an active advocate for migration health for I don't know how many years or decades. And this is not a problem just for us. I can't stop saying that. You see, Canada and other developed countries, immigration for them is not a new thing. But what is different is that most of newcomers to Canada and other countries are coming from different ethnocultural background, different traditional health beliefs and practices. That causes challenge for us. We are grown up in biomedical worldview and then making connection, creating culture, safe environment. This is the challenge that we have. I have been in communication with my colleagues in different countries in Europe, Canada, United States, and that culture safe environment is a major challenge that we are facing. Although we know that that's one of the competency areas for all healthcare professionals. With that note, I'd like to introduce our next speaker, Mrs. Johanna Bergerman. She is presently working as a program coordinator for the Saskatoon Mother Center. Before that, she worked as public health nutritionist in Saskatchewan Health Authorities for many years, as far as I recall. Yes, she has been working there. I had the pleasure of inviting her in 2009, coming to my health promotion class and talking about what she does. And for quite a few years, we were using the video that we had in class for other students. The students were happy hearing what initiative we have in Saskatoon led by her. During her career with the Saskatchewan Health Authority, she trained as a lactation consultant and completed her honor and master's degree in women and gender studies. In the completion of her master's degree, she conducted participatory action research. Those who are in health promotion field, they know what it means. With the women of the Saskatoon Mother Center on their experience with the breastfeeding support. Johanna's interest in breastfeeding from a human rights perspective had led her to work with the World Alliance for Breastfeeding Action, and in fact, Canada, and Balancing Work and Family Alliance. She is presently serving as a senator for the University of Saskatchewan, representing the Canadian Federation of University Women. And I guess more importantly, Johanna is grateful of her supportive partner and family. That includes 8 energetic grandchildren. I can't believe this. I have a pleasure of having 1 grandchild, and I know how good it is. So good for you, Johanna.
Thank you. Well, hello, everyone, and thank you, Dr. Hirani, for your presentation. As you were speaking, I was recalling that much of my interest and passion in breastfeeding comes from my family's immigrant experiences. I was a 5-year-old when my mother came to Canada, and she delivered a baby within 6 weeks of arriving here. I saw her struggle in so many ways, and I'm pretty sure it fueled my interest in this work. So a consequence of trying to make change from immigrant experiences and recognizing how important immigrants are for change in this country, because we all come hoping that this is going to be a better life. And when we recognize where the gaps are, we want to work to make it better. And so with my involvement with the Saskatoon Mother Center, I've really had the honor to hear lots of conversations around what could make things better for women who are faced with challenges as they relate to low income and other difficulties. So what is the Mother Center? It's a women-centered space that provides opportunities for women to gather, connect, learn, and participate in peer support networks. The Mother Center relies on partnerships with other organizations to provide programming in the core neighborhood. And those agencies are the Early Years Parent Resource Center, where we have weekly mother talks and circles, the Saskatoon Tribal Council that supports cooking programs for families, Haven Family Support, where we do craft and chat on a weekly basis, the Core Neighborhood Youth Co-op, which has provided space for training and for meetings, and the Collective on Avenue H, which is a new building built by the city for the community groups that are in that in that area, which has allowed for the Mother Center to have drop-in space available as of this spring. So if I could have the next slide. The Mother Center, what it does is it provides training for formal peer support. And that peer support training includes breastfeeding peer support, mental health peer support, trauma-informed care, and communication skills. Loretta Iris, who's here in the audience, has been a really important part of the Mother Center in terms of providing background and skills in nonviolent communication. We also have elder-led maternity care talking circles that engage health professionals who are invited to listen to participants who want to share their birthing stories. But on a weekly basis, I've been involved with conversations with women, and the women that came last Tuesday would have been typical of the kind of circles that we have on a weekly basis at the Early Years Center. So there were 7 women there, 2 newcomers who had only been here for a short period of time. One of those mothers having come back to the Mother Center circle after becoming a single mother and dealing with domestic abuse. There was a mother there who was part of the YXE group that Brenda has on Tuesdays, and on Tuesdays you didn't have a session, so she came to the earlier center. And this is a mother who really wanted to talk about the differences in the 2 births she had. Both of them were cesarean sections, and the first birth was disrupted with many kinds of procedures. It took her a whole month before breastfeeding was established. The second one, she had wonderful care, skin-to-skin care. The baby was immediately coming to the breast, and breastfeeding was so much easier. She couldn't believe the difference between the 2 births. I said, that's a story that Tanya would like to hear, and really supports the Baby Friendly initiative at the hospital. The other women that were there, one was a mother whose husband or partner is Indigenous. There was an older Indigenous woman and 2 other immigrant women who have been hosts with the Mother Center for a number of years. And what we talked about were the birth stories, and the kind of situations that they would like to see that would be different. So what low-income mothers share about birthing and breastfeeding, the most important one is that the basic needs of income, secure housing, food security are needed for ongoing breastfeeding. The lack of stable employment means that low-income women are more likely to be denied maternity benefits. And without income support, like the mother who came on Tuesday, single mothers are left to social assistance supports that are financially inadequate and create food insecurity. Research demonstrates that for mothers, the stress of food insecurity has a negative effect on their capacity to breastfeed exclusively. And food insecurity that the women talk about increases anxiety that's actually exacerbated by the housing insecurity, the bed bugs, the cockroaches, the tenants that keep them up all night, that they're forced to move again and again and again, and their lack of adequate transportation. So insecure transportation means that they're often relying on the bus system, which isn't always predictable and isn't always a comfortable place for them to be. They also experience increased vulnerability with regards to violence against women and children. And that is both in their home situations, but also in the care that they get in the medical care system. That because of their backgrounds, they appear that they have more difficulties in getting agency and a sense of being heard. And the violence includes things like being called and disrupted in their appointment sessions, not being able to keep going with the same doctor, those kinds of violences that prevent them from actually accessing good care. The other thing that mothers share about birthing and breastfeeding is that there is physical, mental, psychological, and spiritual challenges that require personal resources. A safe, woman-centered space is needed for women to take on the challenges of giving birth, initiating breastfeeding, and taking on parenting a newborn. When low-income women give birth, they often feel judged with regards to their capabilities to take on parenting and breastfeeding. And they're often the ones that are offered formula early with the idea that they're not going to continue breastfeeding longer anyway, and often are given formula as they leave out of the hospital. The challenges are exacerbated by racist attitudes and stereotypes. And one of the things that we've uncovered working with the women at the Mother Center is the actual content of stereotypes. There is some very valuable research, perhaps you're familiar with it, Dr. Hirani, that suggests that there is an initial reaction to every new person that we meet, and it relates to how capable are they, is the judgment we make, and how warm or comfortable are we in terms of coming in a closer space with them. And if you look at those two dimensions, people who are in poverty are often seen as deficit in relationship to using up resources, limited resources in the system. So there's a push away from health professionals in their attitude to taking care, good quality care. And so that's been very illuminating for the women when we've uncovered that and talk about it and figure out ways to overcome those kinds of initial responses with a certain amount of agency. So one of the things that the women at the Mother Center have done is written for themselves, what are some of the guidelines for interacting with healthcare professionals in ways that overcome those stereotypes? Like always having someone with you when you go visit a physician or a medical care service. Always being willing to make sure you know your information that you bring. Always be willing to ask a question so that it cannot be assumed that you're not taking it all in, for example. These are things that they've come up with through their conversations with one another, how to, where they have positive experiences, how does that relay in ways that they can adapt and use those strategies? So those are some of the benefits of the conversations that go on. Income supports are needed for low-income families. And if there's any one policy change that I hear the most about is, income supports. And infant mortality rates, if we can connect these things in terms of inadequacies, infant mortality rates are a key indicator of the quality of care of women and children. And infant mortality rates demonstrate that health inequalities begin in the first year of life. It's 1.9 times higher for infants born to Métis families. It's 2.3 times higher for infants born to First Nations families. These risk factors include inadequate access to education and jobs, inadequate housing, lack of access to health care. And that comes from the Pan-Canada Health Inequalities reporting in 2019. What I hear is that all of that is compounded by food insecurity, unemployment, inadequate social supports, inadequate transportation, inadequate childcare. So I'll turn it over to Sarah. Oh, I should give it to.
Now, I'd like to introduce Sarah. Sarah is a wife. I like the way that she's introducing herself, brings families to hers, right? So Sarah is wife and mother of 4, plus 2, Kukam and auntie. Sarah has worked in the birth community for 15 years as labor and birth doula, breastfeeding support, and parental educator. Sarah has saddled into her calling in the justice system as a reintegration worker, supporting youth in the community as they navigate the colonial justice system. We know that there is always challenges, the way of justice that is served in indigenous culture compared to colonial justice systems. Sarah is the board chair of the Saskatoon Mother Center and facilitator of programs offered by that center. Sarah is Anishinaabe. I'd like you to tell to audience when you start what Anishinaabe means. From 3 to 4, Kinistin Soltu, Soltu? Okay, nation. Sarah will enlighten us with her talk about the needs from low-income families in the core neighborhoods to support lactation and infant feeding.
Thank you. Anishinaabe just means our people. So Soto is the word that colonization gave us to identify us, but we're the Anishinaabe people, so the Soto people. Yeah. She knew. Um, I don't have a whole lot to say in like the details. I think Johanna really covered a lot of the information, and the same with the first speaker. There's a lot of crossover between the newcomer and Indigenous communities when it comes to navigating the systems of, childbirth and raising children. We see a lot. I think that everybody knows about the tubal ligations that happen to Indigenous women, and to hear that that's happening to newcomer women still is incredibly frustrating, because we've done a lot of work to avoid those types of things, and that people of color very rarely receive adequate informed consent. We see Indigenous women and newcomer women coming into the center that face a lot of hurdles. I'm currently supporting a young mom who did not breastfeed. As soon as baby was born, she had made that decision. And I can't help but support her in that decision. She has very little supports, and the biggest one being financial. She's on CIS, and we all know CIS doesn't even come close to helping someone afford to live. She cannot find housing because the only places she can afford are bachelor suites and studio suites, which will not allow her because she has an infant, and that goes against the housing laws. So we are in this like cycle of homelessness, couch surfing, and when you're in that type of environment, and you don't have, someone helping you make your meals and the basic day-to-day things. She leaves her baby at Haven a fair bit, which is an incredible resource for mothers. But to leave your baby, you can't be breastfeeding. And so she knew from the beginning that she was going to be having to access systems and support systems that would interrupt the breastfeeding relationship or end it. And so she didn't want to start it in the beginning. She didn't want her baby to suffer when she went to Haven. And so I couldn't help but help her, achieve those goals to make sure that she was getting the support that she needed, and that did not include breastfeeding. So in the beginning, she's First Nation, so her baby does qualify for formula. But even that process took weeks. I'd taken the baby's father, who's in and out of the picture because of the justice system, to get formula, to buy formula, and he stole a box of formula and came out to my car and got in and started yelling at me, "Go, go, go, go." And I turned around, and there was staff and security around my vehicle taking pictures of my license plate. So I was swearing at him and went inside and had to pay for formula. But it was a really eye-opening experience on how people are managing to feed their babies. Baby does now have a prescription and is fed regularly. but to get to that point was incredibly traumatic for them and me. um, and so we see stories like that pretty regularly. We see the hurdles of housing and the hurdles of family breakdowns. So, especially with Indigenous families, the colonial system has impacted the way families support each other. So we see a lot of women that come into the center that don't have family support. And when you don't have family support, you really have a difficult time in achieving breastfeeding. Women are not learning from their mothers and their aunties breastfeeding teachings, and so we see them being very unaware, and we see the impact of residential school and sexual violence. And so that's one of the things that we often hear from women who come to the center that have not been successful in breastfeeding. Breasts have been very sexualized, and not even necessarily sexualized, but just weaponized. And so we see a lot of women coming in saying that, I don't know if I'm going to breastfeed. I don't think I can have anybody touching my chest. And we sometimes fail to think of how even asking for that type of support is going to look for a mother who has experienced sexual violence. And in Indigenous communities, there's one community in Saskatchewan that 1 year when they were interviewed, 100% of the women 18 and over had face sexual violence and pretty severe sexual violence. So when you hear statistics like that, it's pretty easy to understand why women are having a difficult time in allowing their bodies to be, used. And we see it with women accessing even prenatal care. Allowing someone access to your body is an incredibly difficult challenge. And due to not having financial support, most of these women, we have, if your status covered, you can access a counselor. How many of those counselors are actually trained in residential school support are very limited. So women accessing counseling that is covered through status are often not getting the support that they need from those counselors. And that's a financial hurdle because the sexual violence counselors that are available are usually private practice. If you do not have your own insurance, you're not going to be able to access them. So that's another financial hurdle we see. And then just food. When you aren't sure whether you're going to be able to eat, you're not going to want to breastfeed because you don't know whether you're going to be making enough milk, if you're going to have enough stamina, health to be doing that. So we see that a lot at the center and have been very fortunate to be able to provide a space that empowers women. The center is run by women for women. And part of that is financially supporting women. So all of our hosts receive an honorarium that will not impact their assistance if they are on assistance. And they receive an honorarium. They receive support in training, so programs that are going to help them access, whether it be education or employment. Our goal is to provide safety, a culturally safe environment for all women, primarily new immigrant and Indigenous women. When we were still in a very public space, we made sure that we had an area kind of sectioned off for new immigrant mothers specifically, so that they had somewhere safe to feed their babies when they were accessing our center. Now that we are usually the only people within the facility when we're at programming, we don't need to provide that to the same extent. All of our programs support mothers to empower their families. We provide a men's group where we discuss cultural teachings around breastfeeding. We really talk a lot about sexuality and what what does that look like when it comes to raising children and the safety of breastfeeding. And it's been interesting having a men's group and hearing what the men of these families have to say. And we had one man come in, and he was very adamant that his wife wasn't going to breastfeed because he didn't want to share her. And so we talked about, well, that's very sweet that you love your wife that much, and but talked about how that's not right. And he came to about 4 or 5 sessions, and then I saw him last year, and baby is 1.5 and is still breastfed. So and he is very supportive. He's become a dad that he talks about that children do not need to breastfeed in private, and he's become a bit of a breastfeeding advocate. And so it was a pretty neat experience. We definitely see that if our governments would provide just basic living, the impact that would have on the women we serve. And that's our goal, is to keep providing spaces where women are making a livable wage and hopefully being able to obtain a job where they're going to make a livable wage, where they qualify for maternity leave and all of those types of things. Yeah. Thank you.
There are good questions for you, Carmen. I have a few questions for you, but we leave it for Q&A session. We have one more speaker. Thank you very much. Our next speaker is from Regina. That's Mrs. Andrea Turgut. She's a registered dietitian and public health nutritionist in Regina with Saskatchewan Health Authority. She has provided dietetic service in a variety of urban and rural settings in the community, acute care and public health since graduation from University of Saskatchewan in 1999. Andrea's more recent work in parental and early childhood health promotion inspired her to build community capacity for more safe and supportive public spaces for families to breastfeed in Saskatchewan. With that, the mic is yours. Andrea, I don't know if you have access now.
Thank you. Can you hear and see me okay?
We can hear you, but we can not see you.
Oh,
Okay.
I don't know what happened.
We see you out here online.
Okay. As long as you can see my presentation, that's the main thing for now. So thank you for your introduction, and thank you to Breastfeeding Committee for Saskatchewan and Saskatoon Breastfeeding Matters for inviting me to this discussion today. I'm grateful to be joining from Treaty 4 territory today. As a mother of 3 and a public health nutritionist who understands the enormous value of breastfeeding and breast milk in nourishing children and the benefits to mothers and families, I am very grateful for opportunities like this to contribute to understanding and action that support breastfeeding and food security. So today I will share what I've learned on my journey to rejuvenate a local baby-friendly spaces project. Before I begin, I wish to just very briefly highlight the core vision, mission, and values that guide my work with SHA. As a population health promoter, my work focuses entirely on supporting people to live dignified and fulfilling lives by assisting in creation of environments that support health and well-being for everyone. The work of health promotion and breastfeeding promotion is done by more than just the health sector, however. Tackling the root causes of breastfeeding barriers is the responsibility of all sectors and is about improving health equity as it relates to income, food security, nutrition, and health literacy. My objectives today are to cover how current public attitudes affect safety and comfort of families to feed in public, and how human rights support breastfeeding. The current evidence and voices of lived experience on how baby-friendly spaces initiatives support continued breastfeeding. I will present what families and businesses have found to be supportive for families to feed in public. And lastly, I will provide information on some exciting baby-friendly spaces initiatives happening in Saskatchewan. When I came into my current role, my first assignment, or one of them, was to rejuvenate a previously existing program called Baby Friendly Spaces here in Regina that had lost momentum due to the pandemic. Immediately, I began a literature review, an informal evaluation of the pre-existing program, and an environmental scan of similar programs across Canada. I learned that there are many existing baby-friendly spaces programs, the names might differ, all across Canada that exist through partnerships between municipal governments, community action groups, and provincial or regional health authorities. In Saskatchewan specifically, Saskatoon, Yorkton, Moose Jaw, and Regina are among these. I also learned that the Federal Charter of Rights and Freedoms, the Canada Human Rights Commission, and the Saskatchewan Human Rights Commission all recognize breastfeeding as a human right and state it's discriminatory to interfere with a parent or caregiver feeding a child. So, having not heard of programs such as these before, I naturally wondered, why are baby-friendly spaces initiatives in existence across the country when families should feel free to feed anywhere, anytime they want? It's normal for an adult to eat in public, so why does a family need to be protected to feed a child in public? What I found in literature and confirmed with an informal survey of families with lived experience is that, in spite of families' right to feed, many were uncomfortable feeding in public and unaware of breastfeeding as a human right. Public attitudes around breastfeeding are huge barriers. Although some improvements are noted, much of society disapproves of seeing a mother breastfeeding, especially if uncovered in public. Mothers often opt to either stay home or change feeding methods due to discomfort of having to feed amidst judgmental glances or in a noisy, unclean washroom or their own vehicle, which is also hugely inconvenient. A switch from breastfeeding to formula is a large increase in cost to families. There are also various sociocultural barriers, as Shella mentioned in her presentation, and also Johanna and Sarah, that can increase risk of stigma, judgment, and embarrassment when feeding in public. Public attitudes to breastfeeding can make families, particularly marginalized families, feel doubly stigmatized. Stigma can lower a mother's ability to breastfeed due to anxiety and lowered confidence. In order for mothers to feel confident to exercise their right, initiatives are needed to improve their self-efficacy and autonomy. One key initiative highlighted in literature and requested by those with lived experience is to have safe, comfortable spaces for families to feed in public. Baby-friendly spaces types of initiatives specifically assist in creating public environments in which families are able to immediately and comfortably respond to their children's feeding cues. Typically, participating establishments let families know that they support families feeding their children anytime and anywhere by registering as a participant, completing a checklist, and posting a decal at their establishment. Some programs have websites and some have maps of participating businesses. These spaces have been shown to enhance maternal and public awareness of the human right to breastfeed, increase visibility of breastfeeding, which in turn increases public reflection and normalization. Safe, clean, quiet, and private spaces support families to breastfeed based on their child's cues for hunger, which is key to nourishment and a positive feeding relationship. These spaces also ultimately increase a child's access to breast milk, a safe and nutritionally complete food when they need it. Stakeholder and community engagement across the province indicated a need to raise awareness and build capacity to create more welcoming spaces in retail, restaurants, libraries, recreational settings, and medical offices, among others. In order to create supportive environments for families to feed comfortably and safely in public, it is important that personnel are educated on the needs of their customers or clients. It's also important that personnel are confident and professional in responding to complaints of families feeding in public. Families can be accommodated with or without a designated area, depending on structural or design of the establishment and their budget. Here are some of the needs families have voiced and businesses have incorporated into their baby-friendly spaces. Many items are inexpensive and require only a small addition to an establishment's cleaning schedule. In addition, innovation and cultural sensitivity in these spaces are necessary to best accommodate the needs of all families and ensure equitable access. Because it is a visible sign of support, the decal that is displayed by supporting businesses and organizations in Saskatchewan is reevaluated in 2023. The image being a universally used symbol. Feedback indicated that the existing decal needed to be more inclusive of feeding methods, particularly bottle feeding of expressed milk, and it needed to be a mode to increase awareness of breastfeeding as a human right. In consultation with Breastfeeding Committee for Saskatchewan members, the SHA Baby Friendly Initiative Collaborative, partner organizations, and families, a new decal was designed. This free decal is available by email request, and the contact information will be listed later on in the slides. A task group was then formed made up of dietitians, public health nurses, and lactation consultants to create an SHA branded baby-friendly spaces toolkit to support the community business audience. The resulting toolkit, released last month, consists of a booklet and 3 posters and is found on the SHA Moms and Kids Health website under the Baby Friendly Initiative. It will be used to support a promotional campaign to positively impact breastfeeding rates. It focuses on cue-based feeding and breastfeeding being more than a lifestyle choice, but a human right. The toolkit aims to enhance organizational capacity in municipal facilities, private businesses, and medical offices in the province to ensure that families are aware of and comfortable in exercising this right in public spaces. It also provides businesses with promotional and staff training resources to reduce human rights violations and complaints. The BFI policy has become a priority in SHA hospitals, as mentioned, and a standardized health promotion toolkit supports a more concerted provincial effort to create awareness and action to support those hospitals working towards designation. The standardized toolkit includes public relations benefits that come from actively creating baby-friendly spaces, how to create baby-friendly spaces for diverse needs, tips for staff on addressing client questions and concerns, employer and staff tips on how to support breastfeeding employees, and access to a standardized promotional breastfeeding-friendly logo. The projected outcomes of implementing use of this toolkit are increased number of visible breastfeeding-friendly spaces and parents who are aware of the universal symbol, increased rates of exclusive breastfeeding the first 6 months, and sustained breastfeeding beyond 1 year. Reduced emergency department visits for diarrhea and upper respiratory infections in infants under 6 months, and improved parent-child feeding relationships and eating competence as children grow into adult eaters, leading to healthier body weights, better mental health, lower incidence of eating disorders, less risky behaviors, and reduced risk of chronic health conditions. The 3 posters include the topics, "We are a baby-friendly space," tips for staff to hang in staff rooms, and employee accommodations. The "We are a baby-friendly space" poster is shown here. Additionally, a link to a 7-minute training video developed by 4th year U of S nutrition students and supervised by myself and the practicum coordinator is posted along with these resources and is hosted by Regina Early Learning Center YouTube page. I'll provide links at the end of the presentation. Alongside development of the SHA toolkit, our very enthusiastic local group here in Regina got to work on our own campaign. Our group is a partnership between various organizations passionate about infant and childhood food security, including Regina Early Learning Center, Regina Public Libraries, Early Childhood Intervention Program, Regina Perinatal Health Network, Play YQR, Kids First, SHA, and of course, Mothers. We decided to create our own webpage, graciously hosted by Regina Early Learning Center, shown here, to be a hub for Regina businesses to access the information they needed to be supported locally. With the assistance of a local volunteer photographer, we hosted a photo session, which was super fun, featuring local families and businesses feeding comfortably in public to add to resources and webpage to inspire businesses to participate. It also has a link to the SHA toolkit, a checklist for businesses to self-assess, shown here, and an email address at which they can request a free decal to display at their establishment. The Regina campaign featuring this webpage will be launched this fall, along with social media messaging and participation from the Babe Bump and Beyond Expo. Similar campaigns are in progress in various cities in Saskatchewan. So it is a super exciting time for this initiative. Some next steps to consider on the Baby Friendly Spaces Road in Saskatchewan are local promotion of the toolkit and resources in each of the communities, rural and urban, evaluating the initiative for successes and improvements in affecting breastfeeding rates, perceived comfort levels of feeding in public, and businesses' perceived benefits. And also validating use of the toolkit in healthcare settings and determining if there is a need for a toolkit specifically designed for these settings. As mentioned, here are the links to the resources mentioned in today's presentation, and I can also provide any references should you request them for my presentation today. Please feel free to reach out with any questions on baby-friendly spaces to the email listed, and we will be happy to assist. Thank you once again for the invitation to this very important conversation.
For the presentation, you noticed that we had representation of research, public, NGOs, and also service/policy. You may have heard that one of the major public health challenges that we have is the disconnect between these three. Now we have the opportunity of having all of them in the panel in here, and we are ready to take questions from audience, but you have been sitting for a good time now. Do you want to have some refreshment, just walk around, and then we start question? Welcome to grab something and see it. If somebody has a question, welcome to start asking. Any brave person to start? Okay, so it seems that there is no appetite. Any questions from audience in session and also those who are online?
Those of you in the room,
Yes.
if you have a question, please use the button on the microphone in front of you so that Andrea in particular can hear you and see you. You have to
Yes,
hold that
my name
button
is
in so
yes,
the
my
little
name
red light comes on.
Any questions?
yes, I was trying to ask one. My name is Salome and I'm an international student at the U of S. And I just wanted to find out from the first presenter who did a study on immigrants. I wanted to know if the population also included the immigrants who are international students, because we see a lot of international students coming in with their families. You know, they have, I'm sure their experiences will be a bit different from those who are coming in, who are coming in not being students. So the experiences of students here are quite different, because I am a student. So I just want to know if that's, you included that. I am a student and my own experiences were quite different, because yes, we have experiences, challenges regards to, the economy, because, we are battling to pay our school fees as international students. We are not funded, and then you now have a baby. And some of us are not entitled to the employment insurance, so you have no income. So it's really tough. Like, it's really, I had my baby in September, and I was here alone without my family. So my family arrived the same day I had my baby. Okay. And I've had other students like me say, when they went for their 6 weeks postpartum, a visit to the clinic, and the doctor asked how they were, they busted out crying. And I was like, what? I had exactly the same experience, because you see them going through depression. And there were times where I felt like just walking out of my family. I have 3 children, just walking out and just going somewhere and just staying for 3 days just to clear my head, So in that state, it is really tough breastfeeding. I managed to do the exclusive breastfeeding for 6 months in the midst of it all. At 3 months, I was almost quitting. But, you know, I'm happy I didn't quit. I just managed to go through it. And now I'm having to do, you know, complementary feed. And it's another level of challenge where you're going to the stores to buy milk. I never knew that they could be so expensive like that. You know, last month I spent over $120 just buying milk for my baby. You know, just milk, not diaper. All right. So I don't know. What do you have to say? Thank you.
Thank you so much for your perspective. Definitely, this was one of the sub part of my study with the post-secondary students who are like having the young babies, and I have migrated to Canada either as an international student or either as a permanent student. And your voice in terms of like the voiced concern about all the students who are definitely the international students or even domestic students and with the babies and even having the like a kind of a migration status attached to them is not an easy thing. Definitely it's lots and lots of challenges, and adding to what like the challenges you added, many students even face the issues because of non-availability of the spaces in the daycare centers, and if they are even giving birth to a baby in here and add-on expenses. And I've even met with the students who were telling us that their fees is 3 times more than the domestic students. So even their overall expenses are much more than anybody else. So definitely like for them and overall like the another layer of advocacy I'm doing is like having a kind of a baby friendly initiative on campuses. And the University of Regina has like putting forward this agenda on the roll, and we have like finalized few spaces in the University of Regina's main Regina campus, where they're going to be very soon a kind of a baby friendly room for the mothers who are coming up with the breast pump, and they are providing some kind of the space in there. So now they have finalized the map, but still like few more work to do. So at least I know that from the flexibility is even important from the professors end and from the employers end, wherever like the space is also the another layer of the intervention that could even help them. So from my experience, I would say that the space, the privacy, the flexibility, and even some kind of a support for the mothers from the government is like simultaneously equally important for the international students who are immigrants or they are like have migrated formally or as a student. So definitely you are what you are voicing out is like the general concern of all the students, and definitely more work is required in this area as well.
You, Dr. Hirani, Joanna and Sarah, do you have any experience facing international students coming for asking for service from you?
Yeah, we have had international students access the Mother Center. Primarily, mostly when they've accessed us, it's for like social.
Yes.
And so we've had a mother come to Craft and Chat back when we were at our own old location and partake in some of those programs. I can't think. Yeah, we haven't had any recently. Yeah, not since I'd say that was probably about 2018 that mother was utilizing us fairly regularly. Yeah.
Yeah. Well, thank you. Michelle, are you aware of any services available for international moms at the University of Saskatchewan?
Yeah, we have our lactating room, which is accessed by a key. Sometimes it's difficult to get the key to access, but definitely we need to improve services here on campus.
Okay, so I don't have your name, the lady who asked question. Can you please communicate, Michelle? I am interested in following up on that at the university. You may know that temporary, those who are in Canada on temporary basis, international students, temporary workers, they are somehow neglected population. We have a very good evidence on that. And the risk that they are facing in terms of access to service much more than the other groups of immigrants and refugees. I guess in our capacity at University of Saskatchewan, what we can do, we can follow up to see what services are available and then how we can improve the services existing here. Well, thank you for the question. Any other questions? Yes, go ahead.
I have a question for Dr. Hirani. Because you said you did 2 publications about the breastfeeding and about the refugees mom and other groups. I just want to know that how the support services, especially even in Canada, affect the refugees and the vulnerable people, especially the mothers and the infant. Did you see any specific, effect that hasn't been done in the past years and now it's affecting and they can get a more support and system from the, governors or the other organizations?
Thank you so much for this question. So in past, I would say that there are settlement agencies and they were the collaborators, and even I got a chance to meet with them, and they were the one who were a kind of a coordinating body between the refugee and immigrant and the healthcare providers. So many times like they were trying to help them to connect to the right people. So like that was something, a positive thing that was happening in Saskatchewan very, very effectively, because we don't have one organization but multiple organization. Sometimes like refugee and immigrant, when they are coming in, at times they are not knowing about all those settlement agencies through which they can gather the information. And sometimes people over there, they also mention that the number of other kind of the challenges that they are voicing out, and when they are trying to have the connection through the healthcare agencies, at times things are not like in the effect, like in the they sometimes struggle to find the interpreters for the different languages, because there are many languages that newcomers, immigrant and refugee at times speak. So they at times look for volunteers, and sometimes those volunteers devote their time in the healthcare settings. But for even for the interpreters, at times people feel, oh, she has access to the interpreter, and maybe like things are good and everything would be in a working order. But sometimes it's not the case, because at times if the doctor is telling something technically or medically, something that interpreter do not know exactly how to, because they are not medically trained, they are not the one who have taken any training on dietitian, or they are not even nutritionists, they are not psychologists, they are not physicians, they are not nurses. And when physician tell them something technical, and then the way after translation or interpretation, everything goes to as a message to the main people, like who are the refugee and immigrant, it's something a very different kind of. So sometimes there is a loss of information because of that. So nowadays, like one of the recommendation is that we should have the training of those who are medical students and nursing students, bringing them into account by having them as a volunteer, so that whenever there is some technical terms being used, they can easily just explain them in a simpler way, and not like making anything more complicated. An example is that like one of the physician told somebody that this baby has pneumonia, and pneumonia is the inflammation of the internal lining and all that. And the way it was translated, that the inner lining of the airway and the respiratory tract is burned. So they started crying by saying that everything is burned inside my baby and nothing is left, and how he or she is breathing. So that's something that happens, and many times this is very, very common. So I hope that your question is well answered.
Yes, and I have another question about the milk. Here in Saskatchewan, and especially in Saskatoon, because I'm aware of that. We have lots of donors about to get some milk to other mothers, but we don't have any organization that can support this facility. And because I've known that in BC and other provinces we have, but here in Saskatchewan, this is the barrier that most of the mothers, maybe they want to do the breastfeeding, but this is the challenge for them. They couldn't find the milk that the organization can do, because we have the donors, but we don't have any organization or system that can support and distribute the milks to the mothers. So did you think with all of the research that you did, is there any hope for that, it can be in the near future, some organization or support that can solve this problem? Thank you.
Yeah, so here like the role of milk bank is very like important, definitely. And like we do have Regina Milk Bank, and maybe like other panelists can add, and audience can add to that one, those who know much details about it. But just telling one thing in terms of the context of immigrant and refugee, sometimes they do have a different cultural beliefs, and we do have to take into account those ones, because sometimes in some of the culture, like milk sharing is strictly forbidden, and it's something considered not at all acceptable, just like blood transfusion and similar to. No doubt it's a kind of a situation that milk bank are helping generally worldwide many individuals and many families with the preterm, with the low birth weight babies who really need those, like keeping them as a priority to provide them the mother's milk that is in the pump state, because the first priority by the WHO set is that mother provides her own milk. If it's not possible, she should pump and provide it. And if it is not the case, third option should be the donor's breast milk. And if everything is not working, then on the very last note, there should be monitored formula for some time, and with the kind of more support towards regaining the milk supply for that mother, or that reestablishing the milk supply for that mother. So no doubt like the role of breast milk banks are very, very important, but also looking into the culture and sensitivities involved for some of the cultural group is equally important. And maybe like if panelist or somebody like in the audience. Oh, you have a different question. I thought that probably adding to that one. So for the milk bank, that's something a kind of, and other than that, even mothers have stopped breastfeeding with the support from lactation consultant or from the trained professionals, that could be reestablished. Even if somebody has adopted the baby, they can even breastfeed. So that support is required, and that we need actually more lactation consultants, even in Saskatchewan. I would say in Tonia would add more to that notion, because we have been advocating, and Tonia is very active in that one. So with her group, so definitely more work in this area. Thank you for your question.
Thank you. It was a very good question. If I have a few words on that, the element of culture that Dr. Hirani mentioned is really important. In some cultures, again, you know, the concept of halal, haram, kashur. Some people do not accept any kind of donation when it comes to milk. But just recently, we have a new faculty member in College of Pharmacy and Nutrition, Dr. Chelsea Cochran, that she came with the vision of working with community-based organizations and with the government to open the milk ban in Saskatoon. The initial communication has been done with pediatrics in here and Jim Patterson Hospital and also others. I know that I wish we had her in here. She is in Vancouver, Michelle, right? So we couldn't have her here, but I know that she's very dedicated to have that milk bank opened in Saskatoon. Thank you. You have a question?
Is
Yes.
okay, like everyone can hear me anytime, but what? Okay. No, because the camera needs to go there, and that.
So
It's fine. I can just see the mic. It's actually not about me. Yeah. It's on. Okay. So Sarah, when you were and Joanna, both of you, when I was really struck by how you talked about how what I was getting, and I could be misinterpreting, was that advocating for breastfeeding also means advocating for improvements to these just like structural violence that is going on around like inadequate income support, the much needed continued changes so that maternity care is culturally safe, trauma informed, and anti-oppressive. And so I wondered if there's any other things that maybe quickly you could share with people about the needs to, if we really want to, if people want to make it so that the context is that many of the women that you work with can breastfeed, what kind of structural changes need to happen. It's always the lens I'm looking at things with. So I maybe heard that. And if I'm off base, then just let me know.
No, you heard that right. In my opinion, it's the same discussion we're kind of having across the board in meeting people's needs, right? Not just nursing mothers, but all community members. It's the same reason that we're seeing so much houselessness and addictions, and the list goes on and on. We're not meeting people's basic needs. And when we talk about breastfeeding, there's an assumption that breastfeeding is, because it is, the more financially attainable resource, that's if you think that women's labor is not financially valuable. There's a lot of things like food safety, housing, basic income that really prevent women from accessing breastfeeding, because breastfeeding isn't free. There's a lot of expense that comes with breastfeeding. And we've talked about the transportation to appointments, misunderstanding on whether you have to pay a lactation consultant. So we see financial hurdles. It really does come down to financial, right? Why are people not eating healthy? Because they can't afford to eat healthy. Why are people not obtaining housing? Because they can't afford to obtain housing. So it really does come down to that basic idea of meeting people's needs across the board, not just breastfeeding mothers or new mothers.
In talking about structural changes, one of the things we haven't really talked about is the Baby Friendly Initiative. And certainly one of the things that comes from conversations with the women is that maternity care is very much based on efficient medical care, but not necessarily effective medical care. And that the Baby Friendly is there to protect breastfeeding. And a structural piece that people forget is that the code for marketing of breast milk substitutes really does say we need to be very aware of where that advertising is reaching people. And it's reaching people through doctors' offices. It's reaching people through the nurses who give formula to new mothers when they assume that that mother's not going to be breastfeeding for any length of time, for example. The biggest structural piece that I'm aware of is that formula is the default for nursing time and energy and resources. So having hospital staff understaffed in terms of maternity care so that they don't have time to really support new mothers with establishing breastfeeding is a critical piece to that structural problem.
Any follow-up questions? Thank you.
Hear their perspective and hear them talk a little bit more.
So you are very quiet. Please, go ahead. See if your mic is working. Oh, perfect.
It seems to be working.
Yes.
I wrote a couple things down in follow-up. An invitation, I know that we're in this space where structurally learning is to take place, but I just wanted to add, and I'll see if I can do it while I press this button and bring up my notes here. One of the areas that I noticed wasn't named straight away that I'd invite people who are researching and studying is classism. Just point blank classism. Oftentimes we think of classism is financial, but it's about the way we see each other and the resources and needs we each have. So when you're writing papers or doing a research, I invite you to really look into specifically classism. Through the mechanisms of classism that I'm aware of, and I didn't say my name's Loretta Iris, and I worked with Johanna and Sarah with the Mother's Center with Nonviolent Communication. One of the mechanisms that classism enacts is that the responsibility for change in these structures is downloaded onto the least resourced. That means we're expecting something to turn around by way of the least resourced. So when we can study and include that, we can understand that based on our position, based what has been called privilege or where we're at in terms of seeing each other, we can take our resources and redistribute them. When we come from basic living needs, not only for the women we're talking about, the mothers we're talking about, and the children, and we think about them for ourselves, and we redistribute that which is beyond our basic living needs, we have enough. We have enough right now to change this. We know too that it doesn't need to take time and effort and all these things that we've talked about historically over a long period of time, because we have an example that with COVID-19 and that pandemic, we can make a right turn within 2 years. So I ask you to include classism in your research and ways and means that we have examples that can turn things around in a relatively short time when we band together. And how do we band together? We come together and we talk like this. And the people who are online right now come together and they talk about what's going on, what their impacts are, what happens to everyone that we see when we're walking down the street. And I'd invite you to look at something called the maternal gift economy. The maternal gift economy talks about ways that we redistribute resources in ways that lift our society and enhance our access and enhance our basic living needs and values for each other. That's what I'd like to comment about.
Thank you very much for your comments. Dr. Hirani and other panelists, do you have any comments? Oh, yes, I'm missing. Sorry, Andrea, I'm keep missing referring to you as well. Any comments on the comment that you just heard?
Well, thank you for including me. I don't think I have anything else to add, and it's definitely something that I would desire to learn more about myself.
Thank you. Johanna?
Well, is this on? Yeah. The maternal gift economy, I can't think of anything that's closer than breastfeeding as part of that maternal gift economy. And the investing in breastfeeding is one of the, themes with, that comes out of World Health and UNICEF, that we're underinvesting in that kind of economy. And if we were to look at the impact of breast milk on the economy, if we were actually to collect data on the impacts of it, we would understand that this maternal gift economy is an incredibly important one. It's just been devalued in a capitalist system that prefers to have formula feeding so readily available because it allows for encroachment on women's labor at a time when the child needs the mother or the parent the most. So having dual income families that are struggling because they don't have enough income to support families is part of that other economic system that undermines the maternal gift economy.
I just wanted to point out too, like Loretta said, she's a part of the center and has been for many years. And I think it's an example of why we see results at the Mother Center. All the things she talked about, we're kind of doing that in a little mini form, in our little bubble. Women that are accessing supports from the Mother Center, we everyone's equal at the Mother Center. We're run from hosts up. Hosts of the Mother Center, hosts and participants are the ones making choices and decisions, and the board is there to support them in those ideas. And the board is a volunteer working board. So there is that breakdown of classism in this small little ecosystem we've created, and I think that that's why we see success. And if we could see that on a bigger scale, I think that we would see more success in women's ability to access breastfeeding, because there wouldn't be the same sort of hurdles and the classism. And like she said, it's not just financial, right? It's how we see each other. And so creating environments where women are seen the same as equals and provided the support they need individually. And I think that I'm glad that she decided to speak, because it highlights why we see success in our program.
Thank you for your comments. Dr. Hirani, do you have any comments?
Thank you so much for the comment. And I'm like with my colleagues, like what they mentioned. And I would say that many social, cultural aspects and even like social determinants directly, indirectly affect breastfeeding. And you well highlighted like classism as well, and the way it works with the different populations, especially those who are the vulnerable one. And I would say that the country-based policy even has a different impact. Like I know that in my research, I had a chance to even look around the breastfeeding recommendation for mothers who are with the HIV and AIDS. And it's entirely different in the Western world, like as compared to in other parts, like Canada simply offers them the all those mothers who are HIV positive, and even on the therapy of antiviral kind of a therapy, and with that there is 1% chance to the baby to get that one despite of that therapy. So not taking that 1% chance in Canada, the practice is that every HIV positive mom gonna be getting the supply of free supply of formula. So, in a way, like there is a kind of a debate surrounding the WHO guidelines versus one being followed in here in Canada, and then similar one is in the UK, and in the low middle income country where government couldn't provide the formula to these families, they are saying that still breastfeeding is the best option there, and this is something at times like more truthful and more working in that context, but to what extent like in here. So there are differences countrywide as well, directly indirectly affecting as a social determinant. So I would say that even mother's placement in a geographic location even matters. And even within the same country, if there are provincial guidelines that are varying, so even placement in a specific province, I would say, even make a difference in the life of a mom or who is intending to breastfeed and would like to sustain that for a longer time period.
Thank you very much, Dr. Hirani. That's a very good comment. And for the interest of time, I guess I'm going to be stopping here. But by itself is another subject to be considered. We have literature on that, and in my own research, I have seen the impact of it. So thank you for bringing this up to our attention. We have room for 2-3 more questions before we wrap up the session. Any question, any burning questions from audience? Please go ahead.
Thank you. I would like to ask a question to Dr. Hirani regarding to your studies, the research studies. It's based on like refugees and immigrants, parents. And as you have discussed about the policies and training in professional levels, it requires training for the professionals to how to treat them, how to like culturally inclusive behavior and service. But I have a question regarding, is there any recommendation like to bridging the gaps in the community level? Because I feel like if we start from the community level, the outcome will be more effective in a short time. Thank you.
Thank you so much for this lovely question. I would say very important aspect that what could happen in the community level. And definitely when I was interviewing mom, I came to know that social support was very, very important. And when we talk about social support, most of the time people think, oh, it's family or healthcare providers. But interestingly, mothers who were getting in touch with their religious community and even holding their religious and spiritual practices, they were able to positively breastfeed as well. Sometimes moms believe that if they are more religious or reciting, like for Muslims, they mention that if they recite Quran, and that gives them a kind of a self-confidence, and that makes their own microsystem much, much more stronger. So apart from that, like some kind of like providing them the opportunity to have prayers in the hospital premise or even in the workplaces at times give them a kind of a strength to cope up with the challenges surrounding their breastfeeding practices and even make it more strong. Although this connection is not that very strongly, or like there are so many gaps in the literature on that area. There are like very few literature that talks about and try to highlight. And one of my papers was on the spirituality and breastfeeding. That was a kind of a scoping review. But that kind of a communal practices at times make a positive difference. And apart from that, like above all, maternal knowledge enhancement or awareness raising campaign in different languages really makes it more achievable for a mom to have that access to the information that she can apply directly. And definitely, like at a community level, if there are peer support groups or there are resources in different languages, and even something that could be disseminated in a very, very easy language is something that people are looking forward to. So that's another kind of a very important recommendation that I would emphasize on. And I can just share my own example from the COVID context, where many moms were not having the direct access to the healthcare settings, and they were many of them were my participant, and they mentioned that we don't know what's a new guideline. If I'm COVID positive, should I breastfeed or should I not? And then it was after March 21st when the WHO guideline got released. But it was all the policy documents that were hard to be understandable by like a person who is not having a great command on literature or on medical field or nursing field. So something which is very, very easy to understand had to be developed. And at that time, like a knowledge resource as an animated video was developed and disseminated, and with an option to have it translated in a different languages, and that really helped many mothers. And more than 2,000 women actually had the benefit out of this small resource. And many such kind of a effort could be made in the prayer halls, in the religious centers, or even in the community level, at the neighborhood level, and by involving government as well sometimes. So these are like some of the additional kind of a advocacy effort that can make a great difference.
I just wanted to add that from my labor and birth doula time. One of the things that to this day promote is for community members. So, if it's a neighbor or a friend or, somebody that you've met through work, really helping women, especially women who maybe have communication hurdles, come up with a really strong birth plan that includes postnatal plan, and have things like that they won't be signing any papers put in front of them until they've gotten an English speaking friend on the phone to walk them through exactly what those papers say. And I've seen it work where women come in with very little English and a very strong birth plan, and teaching women words like informed consent. So when they're passed a piece of paper, even if they know very little English, if they can say to that nurse, wait, informed consent, that nurse is going to have a lot of alarm bells go off and like, okay, wait, I've got to take the time for this. So as a community, you know, as just friends in the community, there's ways that we can really support our fellow mothers and friends going through the birthing system and early postnatal. If they're worried about attending appointments and that, you know, they're not going to understand, or if things are not going to be being heard, helping them come up with a list of things before they go in, and really encouraging our community members to do that. So working in the Indigenous community, we often have people from up north that speak English, but just maybe don't understand a lot of the language that's being used in the medical system. And so having plans in place for them when they're going to be traveling down south to be receiving medical care, whether it's in birth or if it's when baby is 2 weeks old or whatever it might be. And we see a really big impact from that. And I think it's a really simple way for community members to support each other.
Thank you very much for, did you receive your answer? Okay, great. Thank you. So we are almost at the end of the session. If I quickly wrap up what we heard today through the excellent presentations of our panelists, Andrea Zinger as well, I won't forget that. We heard about a bigger picture, what is happening. We heard about overall health inequities as one of the root cause of what is happening. So you brought the issue of class and classism. So that's really in that umbrella of health inequity. And then we heard about element of culture in providing care. One side, culturally safe environment for immigrant refugees. The other side, we heard what Sarah said about the commonalities that we see in Indigenous clients that they have as well. So overall, I think that we had some kind of, what you call it, emotional moments that you shared with your clients. I was hoping that we have time to hear some happy moments based on the solutions that you found from the work experience that you had, and also Dr. Hirani, to the literature or the work that you have done as an advocate. So perhaps it's a subject for further discussion later on. So with that, I think what I like to end with that, I think that all of us in this room agree that breastfeeding is not a personal matter or personal choice. I think we all agree that that's a public health priority. This is something that we need to work on it actively, to take action, to provide equitable access to any kind of services that moms at breastfeeding time have that access, and create that equitable environment for everyone. And Saskatchewan is not a foreigner to that, because imagine history of healthcare system in Canada comes from Saskatchewan, universal access to care. So we have been very good in being pioneer, but I think that we are a bit behind when it comes to breastfeeding. And then really it comes to that collaboration between the sectors, so NGOs, advocacy groups, researchers, and policymakers working together to make it happen. With that, I like to provide some gifts for gift of appreciation from the organizers and University of Saskatchewan. But I like to invite Tanya Olson and Brenda Corman to go on the stage for the gifts. Helping me with providing the gifts. So the person behind the scene, Michelle, can you please come forward? So you see that the dress that Michelle has is representing the culture of Indigenous people in Guatemala. It's a beautiful, I guess it's handcraft, right? It's amazing. So again, we have a history of working with Indigenous people with other countries, and Michelle is representing the culture, a very rich culture that we have in Guatemala through my own Indigenous people. Michelle, as a person behind the scene, Dr. Michelle Monroe-Valle, I keep forgetting, we are so close. I see her at my daughter. So has been the mastermind behind the scene, and we are happy and we are very thankful for all efforts that you have behind the scene for this event. With that, Zara, can you please? Yes, take the gifts to the other side and then, yeah, thank you. So Michelle, can you please? Oh, sorry, Yeah, yes. Sorry, I asked you to come help me with providing gifts. Miscommunication. Yeah. Right. So, yes, Michelle, thank you. That's okay. That's yeah. So yeah, I tried to say 2 times, but you see, miscommunication. Imagine in the communication of your clients with you, this happened. Sorry about that. Yes, and yes. Well, thank you very much. I really appreciate your presentation. I hope that next year we have some better things to present to the audience, some actions that have been taken and progress that we had from this point. Thank you, everyone.
We have one good announcement in that Jim Pattison Children's Hospital achieved a silver. Is there anybody on the line? Well, I do have one good announcement. I have to make up for trying to steal your gifts. But thank you to all of our esteemed speakers. Andrea, thank you so much for joining today. And Michelle and Dr. Hassan, thank you so much for, there's nothing like a male talking about breastfeeding to get people to stand up and listen. That's terrible to say, isn't it? But thank you to my baby, breastfed baby, for being in the audience, who's going to spread the news as he grows. But where was I? Oh, one piece of good news to share is that the Jim Pattison Children's Hospital has achieved a silver designation. The BCC and the World Health Organization has said to themselves, you know, this has been an onerous hurdle to achieve. Let's help facilities to along their journey. And so achieving a silver designation means that we have achieved 7 of the 10 steps. And I know that our leadership and educators have heard Dr. Hirani speak before, and it's a tough pill to swallow. You know, they went away from your presentation feeling a little down in the mouth. And but there's always work to be done. We know that there's racism. We know that there's classism. And I would suggest that it's a power. Is there such a thing as powerism? The staff, it's a feeling of power because those patients, when they're in the rooms, they're all in the same gown. But it's very easy to just, run away from the things that need to be done. And they're very simple steps very often. So we'll carry on, won't we? Thank you, everyone.
Well, thank you very much, Tanya, for sharing the good news. So good news starts from here. So let's see where we are next year. Thanks again.